Hello and welcome to The Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies.
Hi, Mike, and I'm Martha Roberts. I'm an emergency medicine NP and assistant professor in Northern California.
Martha, we have had ourselves a month, honestly, like some very big accomplishments for both of us. I work at UT Southwestern Medical Center, and they are a very PA, NP, midwife, CRNA-friendly organization. The advanced tax providers really have it good there. At last count, they employ over 1,150 of what they group together as advanced practice providers, and everyone's got their own opinions of that term, but it is what that is.
First of all, I think it's great. But even more importantly, Mike, they recently had some very nice celebrations to honor two of your professions. And I am thrilled to say you were honored as the 2025 Outstanding APP in Teaching and as well a PA of the Year for the organization. PA of the Year. Oh my God. Like, whoa. Congratulations.
Thank you. It really means a lot. And I told you about these awards over the phone just privately a few weeks ago. And I told you what I thought about your role in those awards was, but I wanted to do it publicly and on the podcast. I'm so tremendously thankful for you pulling me into the orbit of the original emergency medicine boot camp and the Center for Medical Education. Being involved in the organization has opened just so many doors for me professionally, and I can't imagine, honestly, being where I am in my career right now if it wasn't for you, and of course Rick Upada and Diane Birnbaumer. You all have changed my life, and I'm so very thankful.
I'll never forget the time that I was sitting on my bench outside of my house, and we had spoken a couple of times, and it was the moment where I said, we got to get this guy. We got to do everything that we can to get this guy. And I'll remember everything I was doing when it happened. It feels like it was just yesterday, but gosh, it's been over 7 or 8 years now, maybe more. But
I first started in 2019, I think,
yeah.
speaking with the boot camp, and so it would have been at least a year before that, I think.
But it took us 3 years to get you vetted and on board. But once you were in, you were in. And we are so happy to have you on the team. You know, we're a small company, and we really, really honor and respect those that do what you do. And I'm just so glad that you're here.
Well, speaking of you and Diane Birnbaumer, congratulations to you both on your massive achievements, the publishing of the 8th edition of what is one of the definitive texts, really, of our profession. You've got Tintinelli, you've got Rosen, and of course you have Robertson Hedges, Clinical Procedures in Emergency Medicine and Acute Care. I don't put you all in the same grouping lightly. I think it really is an appropriate text to be kind of like the big three of our profession.
So I'll say a couple words about this. This is the book for those of you that are watching the video pod. It's beautiful.
Ooh.
It's this great green color. It's 1,600 pages, and it was released, published on my desk, and it was a massive effort. And I want to mention just a few things about it and how you can get it if you want it, but really the magnificent people who were on the team. Dr. Jim Roberts would be so proud. My dad, love him, miss him, great guy. Couple of things about this edition. It's the 8th edition. So since my dad's passing, Diane Birnbaumer has come to be our new lead editor, and she deserved literally a Medal of Honor. Like, that pretty much sums it up. I can't say anything else. And for those of you who have published things, you know what it takes. A special thanks to all our editors, including one of my favorite people and mentors, Dr. Chris Caldwell from my home at SFG. And we know that you all want to get to our topic, so I'm not going to spend a lot of time talking about this book up front, but what I can tell you, it's a heck of a procedural textbook. It has every procedure you can think of with full color photos, real patients, and videos. As my father would say, it's a project of love, but more importantly, it's one of education and embracing the team mentality. And many of these videos that we did for the book, really incredibly talented individuals like Jess Mason, Larry Mellick, Christine Butts, who did all of our ultrasound section, truly made the book special. I did quite a few videos I've worked on for years just for this edition. Nothing like watching a video of a real patient with a real problem and a clinician fixing it. Rick Bucata did our forward and
Aw.
many editors. I will name them all at the end, but if you want a copy, you can order it on Amazon or just get it directly from Elsevier. They often have sales, 20% off, all the things. So if you want to know more about the book, stay tuned and I'll tell you a little bit about the history at the end of the show.
By the way, just quickly, is Elsevier, do they come to the boot camp? I know there is a desk with textbooks and such.
They do, actually. We get them occasionally, not every time. But when they come, they bring all kinds of texts. They have radiology textbooks, they have procedural textbooks, they have this book. They also have general medicine textbook. They have fairies. They have the 5-minute consult. These are all books that
Hmm.
I really love and utilize. They have apps for all of them. So not only do you get the actual book, you get the code. So, yes, disclaimer, I have worked for Elsevier, but honestly, any book that comes with a code is my friend. Download the virtual copy.
Not a sponsor, Elsevier, but maybe a way you can get the book for a little discount there at the live boot camp.
Yes.
Anyways, it is time for our first segment, the wet read, where Martha and I get 60 quick seconds to talk about something that caught our eye.
All right, so this one's for us. Even though it may feel like we're running around in our clinics and departments, sometimes in circles, in the end, our job is relatively sedentary. I mean, really. I mean, we do run around. I get it. And we stand a lot. But we're not, shooting hoops when we have a 5-minute lunch break. So we occasionally have seasons of physical inactivity in our lives as a whole as well. Perhaps a way to get back into fitness for some of us who aren't currently living a physically fit, active lifestyle is, quote, what we like to call exercise snacks. I love this. Now, I'm not talking about protein bars or energy gels. A systematic review and meta analysis published in October from the British Journal of Sports Medicine. Love that journal, by the way, Mike, for so many reasons.
Are you serious?
Yes, it's
Oh, okay.
fantastic. Fantastic. It examined the benefits of exercise snacks for physically inactive adults and adults 65 years or older, and they defined exercise snacks as structured bouts lasting 5 minutes or less, performed at least twice a day, 3 or more times a week for 2 or more weeks. And this review and meta analysis found that even this small amount of activity, 5 minutes or less, performed at least twice daily, 3 or more times a week for 2 weeks or more, led to significant improvements in cardiovascular fitness in both younger adults and older populations.
That's wild. For physically inactive younger adults, the activity usually studied in the different trials was stair climbing, while leg focused strength exercises and Tai Chi movements were the activities typically studied in the 65 years and older group. And probably wherever we work, we probably have stairs nearby. Okay. Muscular endurance was also improved in older adults who performed these exercise snacks. This isn't a complete fitness solution. These snacks didn't seem to significantly affect muscular strength or metabolic outcomes, and people who are already gym rats or Ironman triathletes weren't studied. But it's interesting that it's interesting that even such a little amount of activity can lead to measurable changes in people who aren't regularly physically active. If I'm in an exercise rut, I am fooling myself if I tell myself I can't spare 5 minutes twice a day, a couple times a week. We link to this study and everything we talk about in all of our episodes at our website. That's 2view.fireside.fm, the number 2view.fireside.fm. Something a little more time consuming, but also more fun than climbing stairs is pickleball. We've all heard about this racket sport that is the fastest growing sport in the US for the fourth year in a row. Martha, do you pickle?
You know what? I love pickles. Okay. I do eat them at 2 a.m. I am a typical eat pickles at 2 a.m. person. But honestly, I am a tennis person. But it's
Yeah.
basically, I mean, it's very similar. The idea of the game is the same. So I would try it, but I'm not sure I'm going to buy it, kind of thing.
I feel yeah. Now, pickles at 2 a.m., do you do it with the fridge door wide open?
I make it a gout sandwich, basically. Are you familiar with the gout
Oh my
sandwich?
gosh, no.
So it's you get a pack of cheese. You get 4 pieces of cheese on 2 pieces of bread,
Oh my
mayonnaise, pickles, and every processed meat that is left over. And that's my gout sandwich. And
That sounds delightful. Okay,
I
well,
got late nights. What do you want from me?
A gout sandwich? I'd love to
Yeah.
take one of those. Yeah. Well, I've only gone once with my wife, Monty, but I really enjoyed it. I got my wife, Monty, a set of inexpensive paddles and did a beginner lesson, and it was super fun, even for me as a tennis player as well. Of course, anytime you have a sport, there's a chance of getting injured. I wanted to focus specifically on eye injuries from pickleball. As the sport has become more popular, eye injuries from the sport have risen 400% in those 4 years we described. Even though you're smacking around what is basically a wiffle ball, as paddle materials advance and people, get more aggressive, the ball can travel over 50 miles per hour. We all worry about strained ankles and pulled muscles from pickling, but I don't think we think about eye injuries. A recent study in the JAMA Ophthalmology Journal suggests that these can range, from the simple contusion and corneal abrasion all the way up to retinal detachment, orbital fracture, and globe trauma. The next time you see a pickler in the ED, or maybe the next time you pickle yourself, don't rule out the possibility of a serious eye injury.
Absolutely. I've seen them. And when anytime balls fly at your face, you need to be wary. So I think one of the biggest barriers to changing these statistics is that it does not look cool to wear eye protection while playing pickleball. I get it. And tennis players don't wear eye protection. But the vast majorities of these injuries could be truly disabling and can be prevented by just simply putting on some eye protection. So consider eye protection made from shatter-resistant polycarbonate. There's also a standard level from the American Society of Testing and Materials, F3164. That would be appropriate for something like this. It's the same specs for eye protection for other racket sports like racquetball or squash. People wear eye protection for racquetball and squash all the time. Come on.
Yeah, in all seriousness, like looking cool is actually really important here, or at least not looking nerdy. I know I don't like getting made fun of, and I'm not going to wear something that leads to that. We went through this in the army as well. Like there were so many eye injuries in combat that could have been prevented if people just wore their dang eye pro. And so what happened was at a certain point, the army was like, all right, we give. They started making cool looking eye protection and also kind of pushed a public service campaign of the dangers of not wearing the eye protection. And I still wear my cool looking eye protection that the Army gave me over 10 years ago today in the ER and the urgent care when I'm doing anything wet. I learned, thankfully not the hard way, that body fluid exposure happens fast. You are not going to like matrix dodge blood or pus or other spatter that comes shooting out at you. Sometimes it is hitting you or ideally your eye protection before you even realize what's happening. I'm going to start bringing it to the pickle courts as well.
I love it. And the other thing that this makes my brain go to is when people make their CV for new jobs. So the first couple things we talked, no, I'm not kidding. So in my CV, it's like, what are your other goals and hobbies? And I've had listed in there for literally 20 years, mastering the 15-minute workout because it's almost impossible for me to do 30 minutes. So I always like to talk about what I do for 15 minutes. It's a great icebreaker. And now if you have a cool sport, you can talk about the fact that, hey, I'm really into preventative care for, potentially these eye injuries. I mean, we need our eyes to see. And having like just a backup of something to talk about when you're in an awkward moment during an interview, think about our podcast and maybe it can shed some light on these more difficult conversations.
How funny. Well, speaking of eye injuries, that was just one of the topics that I had the privilege of lecturing on at the most recent running of the original Emergency Medicine Boot Camp. If you missed it live this year, no worries, you can get the streaming version today.
'Tis the season, Mike. NPs and PAs, you need to look at your CME account and try to figure out how to use it before you lose it. So use it with us. www.ccme.org. That's www.ccme.org and take advantage of our courses. We've got everything for everybody. And I feel like we have something new every month. It's been really fun. And honestly, our biggest new launch is the brain course. I remember we were talking about this maybe 2 or 3 years ago, and I was like, man, it's going to take us a while to get this launched. But no, it's here. It's 13 hours, more than 13 hours actually, of CME dealing with the noggin, neurological emergencies, and as always, national experts in emergency medicine and neurocritical care.
Yeah, brain stuff is tough, and the decisions you make at bedside go well beyond do I order a non con head CT or not? There's way more decisions to make than that.
Absolutely. And then, of course, there's the EMC2 course. That's the Emergency Medicine Cardiology course taught by Amal Mattu, the Airway and Lung course with Rich Levitan, and the EM Cases Summit led by Anton Hellman. You will find something, I promise, that you're interested in. And if you want that live experiences that we offer, please plan for 2026. We're looking at dates, so stay tuned. And we also have our emergency medicine literature review courses, the acute care courses, and all of those dates and conference locations will be posted on our website, www.ccme.org.
Yeah, that's the one that is not in Vegas. I think maybe they do one time in Vegas, but the vast majority are other cool places like New Orleans or Colorado or places like that. Nice discounts for signing up early. It's never too early to be thinking about next year.
Yeah.
Well, next it's Dry Scan, where we penetrate a little deeper into two other topics.
Yeah. Think about next year and think about gabapentin in your life or someone else's life. The next time you consider prescribing or refilling gabapentin in your patients, we want you to really have some good information armed for this. I had no idea, Mike, about this. As of 2024, gabapentin is the fifth most prescribed drug in the US.
That's wild.
Truly, no idea. And the number of prescriptions has tripled from 2010 to 24. It's FDA approved as an anticonvulsant to treat epilepsy, for neuropathic pain, for shingles as well. And there's an extended release formulation that's approved for restless leg syndrome. And that's about it. But a study came out in the Journal of Anesthesiology. Again, we've mentioned three of my favorite journals today. Anesthesiology has some really interesting things. So it suggests that gabapentin may be misused in the management of acute postoperative pain. Not surprised just a little, but let's talk about this. Multimodal analgesia is important for a lot of acutely painful conditions like fracture pain, musculoskeletal back pain, postoperative pain. Don't just take one drug. Consider taking multiple drugs to hit multiple receptors. We consider ice or heat. We consider elevation. We consider multiple modalities to treat acutely painful conditions because it may treat pain better than just one modality by itself. And it may allow people to take less of one particular drug and limit that drug's side effects. And I know that personally listeners have probably felt this and understood it. I mean, the same thing goes for every other system, right? GI drugs, cardiac drugs. You want to take as little as possible. I mean, antidepressants, anxiolytics, and anti-anxiety drugs, all of those things. We want to take the fewest amount to cause the least amount of side effect. We often see patients who come into the ED or urgent care who have had a recent surgery and their pain is not adequately controlled. First, of course, we rule out any emergent complication from the surgery. We know that. And if we don't find one, then we've got to figure out a way to figure out if there's anything missing in this person's pain management plan that we can suggest. This study in the Journal of Anesthesiology was a multi-center, double-blinded, randomized control trial. God, that's really hot. Of 1,196 patients who had major cardiac, thoracic, or abdominal surgery. So, neck to pelvis, right? The control group, they didn't have any gabapentin, no gabapentin. The primary outcome was length of hospital stay. And the median length of stay for gabapentin group, 5.94 days. The median length of stay for the placebo group was 6.15 days. Not statistically significant. In terms of secondary outcome studies, in this particular scenario, there was also not a meaningful improvement with gabapentin takers in opioid consumption, acute pain, or quality of life. There was actually a higher incidence of pain at 4 months post-op in patients who were taking gabapentin.
Yeah, one article from 2018 suggested that gabapentin was prescribed off-label 95% of the time, right? I mean, and off-label doesn't mean bad or wrong, but you really have to consider, well, If it's off label, if no one took the time to obtain the FDA approval for that indication, you will have to wonder what is the evidence behind how it's being used for that off label indication. We do have links at the show notes. Go to 2view.fireside.fm. That's the number 2view.fireside.fm to other articles suggesting gabapentin is associated with increased dementia risk. Gabapentin can also increase dizziness, fatigue, and drowsiness, especially not great in patients who may already be on sedating drugs, and this may translate into increased risk of hip fracture, especially in patients with chronic kidney disease or who are already frail to begin with. In addition, gabapentin has also become in demand on these streets as drug users have found that it can increase the highs associated with heroin and cocaine use. Nearly 10% of overdose youths and overdose deaths in 2020 involve gabapentin, and it's all in those show notes. I wanted also to talk about a few reasons to be concerned about a topic we covered on a previous podcast episode. 7.8 million reasons, actually. After a 2-week medical malpractice trial in Florida in September of this year, a jury awarded the plaintiff $70.8 million in damages after the defendant, a nurse practitioner, treated the plaintiff for headache 2 days before the plaintiff went on to, the patient rather, same thing I guess, went on to have a stroke. First, I just want to talk a little bit about the case from what has been reported on in newspapers and see if you can spot any issues. Ms. Chaka Stewart, who was then a 38-year-old woman, presented to a freestanding ED by ambulance, concerned about the, quote, worst headache of her life. She was suffering from diabetes and obesity and had, among her medications, oral contraceptives. There is some dispute here between the defense and the prosecution about whether the treating nurse practitioner, Heather Anderson, obtained a history that these headaches were similar in quality and severity to previous headaches. That's what Ms. Anderson documented, but there's some, conflicting testimony from the plaintiff team. Regardless, after some blood tests and a combination of headache medications to treat the pain, Ms. Stewart was discharged. Over the next 30 hours, she started getting worse. She got left-sided weakness, and so she was transported to a different hospital where it was discovered that she had suffered a stroke. Now, hopefully you're thinking, 38 years old? Wow, that is so young to be having a stroke. You're right. This is much younger than the typical stroke patient. When you have a patient who sounds like they're way too young or way too healthy to be having a stroke, but it sure looks like they're having a stroke, I want you to think about the possibility of a cerebral venous thrombosis, or CVT, a blood clot in the veins of the brain. We covered this condition in episode 41. Check the show notes, including risk factors and treatment. I go into more detail about potential risk factors on that episode, but broadly, just like other clots, it's important to think about endothelial damage to blood vessels and coagulopathy as increasing the risk of CVT. Many oral contraceptives, specifically ones that contain estrogen, can contribute to coagulopathy or increased risk of clots. And now this particular condition, CVT, is very rare. We're talking about 3 to 4 people per million, as opposed to regular, quote, regular strokes as a whole. Those hit about 1,500 people per million. And I don't feel like the press release from the plaintiff attorney is super helpful. They mentioned Ms. Stewart's diabetes as an increased risk factor for, quote, stroke, but it's not an increased risk factor for CVT. Further, the plaintiff attorney insinuates that if Ms. Anderson had just ordered a CT, this would have been figured out, except because this is a problem with veins. You would typically need a vein study to find a CVT. In this case, that would be a CT venogram, different than a CT angiogram that is typically used in stroke studies because the CT angiogram focuses on arteries.
Yeah, this is a lot and very unfortunate, all of it. But from a medical legal perspective, this is the largest judgment that I can recall ever seeing against a nurse practitioner. Of the 70.8 million, 51 million of that is going towards past and future pain and suffering. But the defense is appealing to drop that to 300,000, citing a law that limits non-economic damages for Medicaid recipients to that number. And this case is not going away anytime soon. I expect to hear more about this, Mike, in the next few months, and I think it's going to yield a lot of med mal food for thought.
Yeah.
Yeah. What a case. All right, we've reached the final segment. And this segment is something that, believe it or not, Mike, people are asking for this, They were asking for us to cover some of these topics that, we learn in school, we see in practice, and we treat. But it's like, hey, let's get a refresher. So segment 3 today is going to be a refresher on diverticulitis. So I want to start off this third segment by saying that I myself have, or I'll say I sort of have, missed diverticulitis a few times. I know this because they come back the next day. Okay, so they still have symptoms, but the day before, their treatment and their workup, it wasn't incorrect. Their symptoms just were not severe enough to buy them some radiation. But that's the tricky thing about diverticulitis. And if you listen to nothing more of what we say in segment 3, just know that diverticulitis can be tricky. It can be straightforward, but it can also be tricky. So sometimes the labs can be normal, but the pain can be obtuse. So let's take a minute to take a deep dive into diverticulitis. The early stages of the disease can be nefarious, and you too can be fooled.
Yeah, this little chat today between us is inspired by a recent review article in JAMA, the Journal of the American Medical Association. We'll have a link to the show notes to that review article. Let's talk pathophys first. That's just so important to start there, Martha. Diverticulitis is inflammation, and sometimes there's even perforation or infection of one or more diverticula. And classically, they're described as, quote, outpouchings in the wall of the colon. I call them potholes to help people understand kind of what's going on here. Many people develop these diverticula, a condition called diverticulosis, but never have trouble with them. The osis becomes the itis when those pouches, those potholes get inflamed or even infected. Worst case, the inflammation gets so bad, these thin-walled outpouchings perforate, they pop. And now you've got a real problem because all that poop in those outpouchings is now spilling out into the abdominal cavity, and it's a big deal. This can lead to getting an ostomy, this can lead to surgery, this can even lead to things like sepsis and death. So let's talk numbers. In terms of prevalence, about 30 to 40% of adults over the age of 50 have diverticulosis, and that number will double to about 60 or 70% by age 80. Pretty uncommon under age 40, but the review article and the authors do suggest that we are seeing higher and higher rates of diverticulitis in the young, so don't sleep on that. Now, how about progression from osis to itis? Only about 4 to 15% of diverticulosis sufferers will ever develop itis of those osises in their lifetime. The vast majority, 90%, give or take, will never have inflammation or infection, and they may have their diverticulosis just kind of incidentally discovered on imaging or colonoscopy or whatever, because it doesn't cause any symptoms, and you don't find it until you happen to be looking for something else. So, if you do the math there, carry the one, if you take 100 adults over 50 with diverticulosis, about 80 to 95 of those 100 adults will live their entire lives with those diverticula, those outpouchings, without ever having had diverticulitis. But when we miss that, again, complications can become extreme. Risk factors of conversion to diverticulitis include older age, obesity, smoking, regular use of NSAIDs, and perhaps altered gut microbiome or motility changes from, take your pick, lots of things, right? Now, you didn't hear me say anything about a high fiber diet there, and there's a reason for that. despite how much we harp on fiber, we've been taught recently, right? It used to be like popcorn and nuts. You can't have your popcorn and nuts if you have a diverticulosis. Well, now it's fiber, right? Now it's like, oh, that was old wives' tale, but fiber really is the problem. The role of fiber, if you look at the literature, is actually unclear. Although the comparisons between different world populations previously reported a significantly higher prevalence of diverticulosis with the quote Western diet that is traditionally low in fiber, there was a colonoscopy based study in the US that included over 2,000 patients. And in those Western patients, they did not find any differences in patients with and without diverticulosis, regardless of their quote dietary fiber score. So this might be one of those things where like eggs are bad for you. No, eggs are good for you. No, eggs are actually bad for you, right? It's like
Right.
first it was nuts and popcorn, then it was fiber. I think we're still trying to sort out how diet plays a part.
I think there's so many variables, Mike, and uh, honestly, I say this later in the show as well, and I've already prepped to know to say it. Do your own Cochrane database search. Look at some of these
Sure.
studies, and then think about what this patient is doing, saying, and presenting with, and then you can, talk about the fiber stuff with them. But let's go back to the classic presentation of diverticulitis, or even maybe a little diverticulosis. It really depends because they still can have some pain. It's typically unusual for just diverticulosis to have any pain at all. The itis is what is the inflammatory part. But when they're coming to you with true diverticulitis, they've got left lower quadrant pain. It's very specific. It's not all over their belly. It's not up in their chest. It's not down in their pelvis. It's the left lower quadrant because of where the colon is. And they often might have a fever, leukocytosis, nausea, vomiting, changes in their bowel habits. Some might say constipation, some might say diarrhea. And on exam, again, over and over in the years that we've talked, physical exam is so important for this diagnosis. You got localized tenderness, maybe some guarding, true guarding where, ow, they slap the hand. They slap the hand right out of the way. Or maybe they have a palpable mass, or maybe there's an abscess. And that really, when they have an abscess, it is a shocking pain. But physical exam alone is not highly sensitive, but it is indicative of I need a scan.
Yeah, and it can be kind of non-specific as well. The symptoms that are kind of classic diverticulitis symptoms that can overlap with other acute abdomen presentations. Sometimes appendicitis shows up as left lower quadrant abdominal pain. Okay, sometimes ischemic colitis, inflammatory bowel disease, kidney stones, gynecologic causes like TOA or PID. So when you have focal pain in the abdomen and tenderness, especially when there's guarding, you still have to take a step back, keep a broad differential diagnosis. What are some red flags where there could be complicated disease of any sort? Rigidity. And just to be clear, what is rigidity? Because these are some of these terms that we kind of throw around there, like guarding, and like we say these things, but it's like, do we really know what these things mean? So rigidity is like if you're pushing on some belly that is already kind of like flexing. Like how muscle feels when you flex the muscle, it goes from kind of like, kind of like limp to like hard. When you push on a rigid abdomen, it's already hard from the get-go. It does not tense up after you push on it. So that's rigidity. Of course, rebound tenderness or rebound pain can be concerning, where you kind of gently push in and you quickly withdraw your hand. I'm not asking a person how that feels. I'm watching their eyes, because the eyes tell the story there. If you yank your hand back and they have rebound pain, they're going to kind of like startle a little bit. Of course, hemolytic instability. So if you have high heart rate, low blood pressure, free air on imaging, all these things, all those presentations, whether it's physical exam or diagnostics, point towards some sort of complicated disease requiring more aggressive management.
Absolutely. And this is the thing, Mike, when I was in school, My attendings were very specific about the signs and symptoms of certain illnesses and diseases, especially those that caused, quote, a peritoneal abdomen. And when you consult a surgeon, it's even more important to know these definitions because they don't care when you say certain things. They want to know what is really happening and is this abdomen, quote, peritoneal. So when you consult a surgeon, know the definitions. I was teaching a student the other day. I asked them to tell me what it meant to have a peritoneal abdomen because they mentioned that the patient had, quote, no peritoneal signs. So we're going to get nerdy here for a minute, and we're going to talk about the importance of what we call peritoneal abdomen. So when a surgeon describes a peritoneal abdomen, they're using a shorthand for a patient that's showing clinical signs of peritonitis, okay? That means inflammation of the peritoneum. And by the way, this is, again, a tricky diagnosis because the body sucks at understanding pain in the belly. It is not good. It is not good at understanding it. Meaning, like, you could have a gallbladder issue under your right diaphragm and you have pain in your shoulder because you're stimulating nerves, in your right upper quadrant when you have cholecystitis. But when you have a perforation or you have diverticulitis, the belly, it's just a bad, the body sucks. They just know that the belly hurts. So essentially, when you have peritonitis, this means there's inflammation of the peritoneum. That's that thin membrane lining of the abdomen cavity that's covering all the organs. And it's one of those phrases that when uttered in your trauma bay or the ED makes everyone kind of stand a little bit taller. And here's what a surgeon would mean by it and what they're looking for. So number one, the physiology behind the phrase. The peritoneum has an abundant sensory nerve bundle, okay? Especially in the parietal or outer layer. And when it becomes irritated by infection, blood, bile, gastric contents, or even perforation in this case of perforated diverticulitis, those nerves react violently. And the muscles of the abdomen wall reflexively contract to protect the underlying organs. And that's basically what you just said, Mike, the guarding or the rigidity. And number two, your exam findings that earn this label of, quote, peritoneal, exquisite tenderness, even to light palpation. Involuntary guarding. The abdominal wall muscles tighten on their own, even if the patient tries to relax. Rebound tenderness. The pain worsen when you examine with your hands quickly lifting away. The inflamed peritoneum snaps back into place. It sucks for the patient. You will know. This board-like rigidity, a belly that feels like a plank. It's hard. Absent bowel sounds, the intestines, they're going on strike, yo. Like, they're legit like, no more. Thank you so much. We'll talk to you later. And then, of course, pain with movement on percussion. Patients often lie still, avoiding even small shifts.
If you try that rebound maneuver, right, you put your hand, you push in a little bit, and you yank your hand away, and the patient goes, can you try that again? That is automatically a negative for rebound pain, right? Nobody with rebound pain wants you to do that again. Okay,
Yeah.
so if they're not sure, you don't have to do it again. Just tell them, like, okay, well, like, we can move on to other stuff. Like, that second try will not be any better.
Mike, I love that. This is why we do this show. I mean, legit, that is a thing. And I don't know, we'll call it the Mike Sharma thing.
Yeah, like the Sharma sign. There you
Right.
go. Yeah, which is a negative predictive value for peritonitis, right? Because it's clear when a patient is that painful when you yank your hand away, and patients, as bizarre as this sounds, sometimes they want to please in interesting ways, and so like if they feel like you are leading them in a certain way, they'll go, oh yeah, like it totally hurts when you wiggle my big toe. Yeah, my hair hurts. Yes, totally it does. So like when you start ask certain questions, like that's like the pan positive patient where it's like everything is positive. It's like, all right, like sometimes that in itself is kind of like, let's reconsider how legit this is.
Wait, Mike, I have to remind you, if you listened to our last episode, the ponytail headache, take their ponytail out. See if it helps.
I texted you, right, about a week or so after
Yeah,
that
you
podcast.
did.
I was like, I think she has a ponytail headache, this patient that I had. Anyways, well, so the surgical mindset, once you find peritonitis and you tell a surgeon, if you use that phrase peritoneal signs in and around a surgeon, then they're already thinking, I need to take this patient to the ER sooner rather than later.
The OR, the OR. Get them out of my ER.
Yeah, exactly. It doesn't mean like it's not a why, it's a what.
Yeah, it's like, well, when can I put a scalpel in?
Did I ever tell you the story? This brief aside here, right? So I saw a resident go in to see one of my patients who I thought maybe had kind of like an early cholecystitis, right? And so to me, he walks out and to me he's like, I don't think we're gonna take this patient, but we'll see. I'll talk to my senior. And like 10 minutes later, I see the whole entourage. Like he walks into the patient's room with the attending, with all these, interns and med students, whatever else, and they walk out of the room a few minutes later. And so the resident's talking to the senior, and the resident goes, "Yeah, so I don't think we're gonna need to do surgery on this person." And the attending goes, "What does it say on your jacket?" And the resident's like, "Surgery?" And the attending goes, "That's right. We're surgeons. We're taking out this gallbladder today." I was like, oh my God, that was like such a surgery move right there. Like, what does it say on your jacket?
Boom. Surgeons want to operate. I get it. So just chill, in some situations. But if you say peritoneal, be ready for it.
Yeah, surgeon's going to want to surge. So right, we don't know what the peritonitis is from. If you find those abdominal signs, it's a what and not a why, and it could be from diverticula perforating. We've got a tear in these thin-walled outpouchings. It could be because bowel is dying and now a dead bowel has become inflamed and then maybe infected. Maybe an ectopic pregnancy has ruptured. Like you mentioned, Martha, blood is so irritating to the peritoneal cavity. And so a ruptured ovarian cyst, a ruptured ectopic pregnancy, trauma, someone who has torn their spleen or their liver, all those things are intensely irritating to the peritoneum, that lining of the abdominal cavity. Once you say peritonitis, like you can't unring that bell, that really narrows the options down. Are we going to the OR now? Are we doing serial exams and going to the OR later if it doesn't get better? Are we doing some sort of advanced imaging? You're not going to want to just send a patient home with nothing if there are peritoneal signs.
Well, listen, when you call the surgeon and you say they're peritoneal, this is what you're going to hear from the surgeon. Can you hear my sound effect?
Work. No.
Oh, it's such a bummer. So for those of you that couldn't hear my sound effect, I have this great little bullhorn that goes, bow, 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 bow. There you go. So essentially a surgeon's like, dang, like I got some business tonight. Like, let's do this. Let's resuscitate. Yeah.
Like that.
Yeah, I love it. I think we should have a show just of that noise. But just to remind you, a good way to rule out a lot of these female problems, you just get a pregnancy test. And if you're like, hey, I'm not 100% sure, get a blood level HCG and just be done with it. And that's fine. No one will fault you for that. But I'm going to tell you the poetic translation here, just to kind of summarize this. If you want to say the way a seasoned surgeon at my hospital might teach a resident, a peritoneal abdomen doesn't lie, okay? The patient guards it for you. The skin's cool, the muscles are rigid, and even your lightest touch makes them flinch. And that's not a lab test. That's surgery waiting to happen. So in short, a peritoneal abdomen is not just sore. It's an abdomen that has literally declared war. And to surgeon, that you're consulting, it's the body's unmistakable SOS for immediate intervention. So I'm glad we covered that.
Yeah, and it's funny that you mentioned some of those things. I didn't think about the coolness of the skin, but that makes sense. The lightest touch. So sometimes if you're really trying to like suss out what's going on here, you can accidentally, quote, jostle the bed, kind of like hit it with your knee or bump it with your hip. And that jiggling of the body by you hitting the bed, that's kind of like a distraction test. Like when you've got hands on their belly, they may be like, oh, oh, oh. But if you like hip check the bed and they don't even flinch, then it's like, that's kind of weird. Like everything else was so sensitive in terms of causing pain.
Right. So, Mike, let's get back to the diagnostics and labs for suspected diverticulitis.
Right. So with the itis, the inflammation of these diverticula, you're going to check your complete blood count. Leukocytosis suggests it, but of course you can have leukocytosis for any old reason, for pain, for anxiety. CRP and maybe ESR can be associated with severity if they're elevated. That can be kind of sometimes a tiebreaker. You get like your CMP, you get your urinalysis to look for other things going on there. Is there any sort of liver or kidney stuff going on? These aren't definitive though. Like you're kind of assembling a picture here so that if it's not clear, if you're deciding like, do I get imaging, because like you can't unring the bell of radiation, right? So if you're trying to like figure out, do I irradiate this person, you start by building a case with some of these things. Okay, so next, pictures, right? CT is king here, right? CT scan of the abdomen and pelvis with IV contrast. Now if there's a contrast shortage, if there's a true contraindication to contrast. And by the way, listen to our podcast with Robert Tubbs a few episodes ago. I was bemoaning my fate to him a few days ago when the radiology team wanted to do like a hours long allergy protocol on this patient, when it's like, oh my gosh, we don't need to, because she had a problem with some shrimp a few years ago. But anyways, CT scan, abdomen, pelvis with IV contrast is the king of the jungle here. Why? Because that IV contrast will help look for things like abscess, like perforation, like fistula, like a surgeon's got to go in there, basically, right? So you put it all together at the end of the day, because honestly, sometimes that CT scan is not the donut of truth. As you know, sometimes a CT scan or the interpretation of the scan by the radiologist will say, cannot rule out abscess, clinical correlation is recommended. So you've got to put it all together. Does the labs, does your exam, does that also suggest abscess beyond the questionable imaging? So, for example, right, if you've got CT findings of wall thickening, that could be like inflammation of the osseous. And then you've got some pericolic fat stranding. Oh no, that could also be some inflammation kind of spreading out there. If you see an abscess, gas in the belly is concerning. Gas in the colon is just a fart waiting to happen, but gas outside of the colon suspects that makes you think like, oh no, that's escaped now. It shouldn't be in the belly unless the person just recently had some sort of a laparoscopic surgery. That's the only reason I want to see air in the belly, is if you just got out of a laparoscopic surgery recently, okay? Or if there's free fluid. Now, free fluid is tricky because that can be physiologic in the ladies, rare though in gentlemen. So be wary of even just free fluid in patients where you shouldn't have fluid that is free.
Yeah, Mike. So, that is a great point to make. But I do want to focus a little bit on the management now in the ED and our disposition decisions. So this is why that JAMA article is great. Okay. So here's why we split the story into uncomplicated versus complicated diverticulitis. When I say the word complicated, I like to be like complicated because like it's causing us like complications. Like we have to work harder here. So uncomplicated diverticulitis, by definition, is inflammation confined to the colon or the wall or the diverticula without abscess, without perforation, or generalized peritonitis. And we've already reviewed what peritonitis is. So for many patients, this can be managed outpatient, depending on pain control, reliability for follow-up, immune status, comorbidities, all that stuff. You need to take it into consideration. Recent evidence shows, and I'm going to, just quote what the JAMA article said, routine antibiotics may not be required in mild, uncomplicated cases. Selective use is now preferred. And again, I told you this was the big main takeaway I took from this article, which is why when I saw a patient with maybe diverticulitis that looks so good, so good. I was like, yeah, I'm not going to scan you and I'm going to send you home. And if you're worse, you come back. She did. But most of the time, they don't.
Right.
But anyway, I digress. The ED tasks for you are pain control. So you're going to avoid heavy opioids. Why are you not doing that? Well, you don't want motility concerns now. Ensure the patient can tolerate oral intake. Document that the patient was eating McDonald's. You can do that. Outpatient instructions, timely follow up, maybe a short liquid or soft diet. I mean, quite frankly, Mike, I think you and I could both benefit from that like today. Like, why not? And then your discharge criteria may include, you got stable vital signs. You're able to tolerate PO. There's no signs of complication. And what I mean by that, okay, listeners, please give an example of no sign of complication. What does no sign of complication mean in a medical legal chart? What it means is you re-examined the belly. You saw them eat. You saw them have a bowel movement, meaning they told you they went. I mean, you don't have to watch them poop. Jesus. So reliable home support. You need to focus on that. They're not alone. They're not homeless. And then, of course, maybe in some hospitals, like our Kaiser hospitals, you've arranged follow-up.
Yeah. I'll this is where I'll kind of sum things up in my MDM, right? The MDM is not where you just restate this is a 24-year-old female who, like, yeah, we know we can read the rest of the chart, okay? Tell us why you're making these decisions. And so that's where, like today, I had a patient with abdominal pain. And so I put in, the MDM, no peritoneal signs on serial abdominal exams, vital signs stable, tolerated PO in the ED. I discussed abdominal pain precautions and instructions. And so like that's where you're really putting the really salient points into the chart, the MDM, why you're not scanning, why you're not calling the surgeon, things like that.
And Mike, I'm
Don't
sorry,
just
I don't want to interrupt you, but
yeah.
this is why it's so important that we covered what actually peritoneal means.
Yeah,
Because
totally.
if you're going to use a phrase, and I do so many medical legal cases, I just finished another one, and it's like if you're going to say something like no peritoneal, signs, you better frickin' know what that means because you're going to be asked, and if anything in your chart goes against that, you're screwed. And I don't mean this just to be like, oh, only practice defensively. But like you got to know your stuff. You got to know what you're saying when you chart it. Sorry, I didn't mean to interrupt.
No, I agree. You have to know what every word means, and ideally, the why behind why you're doing things, not just because someone told me once,
Mm-hmm.
right? Because like that's where I feel like before I get into complicated diverticulitis, right? Like I feel like some of these things for me for diverticulitis were kind of like, well, I heard one time that fiber was a thing, and I heard one time you can get away without scanning, but like it's so nice to have like Big JAMA, like Mama JAMA coming up and saying, hey, these are things that we believe are true. And so you can kind of, even though there's no definitive text necessarily for diverticulitis, when you have one article like this summing up so many important decision points for us in the ED, do I scan or not? Do I discharge or not? It's great to have an article you can point towards like this one to say, this is kind of why I did this.
Right, right.
Well, yeah, I like to say, would I say complicated? I like to, in my head, isn't it like Avril Lavigne? Like, why'd you go? Anyways,
Right.
complicated diverticulitis. It's not Kelly Clarkson, which we'll get into later on, but complicated diverticulitis, by definition, that's if there's an abscess. That's if there's a perforation. Maybe a fistula where the colon is now collecting to another part of the colon, or maybe the bladder. Yuck. Obstruction, sometimes inflammation can cause an obstruction, especially if there's pre-existing kind of like adhesions like from previous surgeries, right? If there's free air, again, that implies air is leaking out of the colon somewhere, or if just the whole abdomen is peritonitic. Like it's one thing if the rest of the abdomen is kind of fine, but you go to the left lower quadrant and it's like, ooh, they've got like rebound there. If your whole dang abdomen, left to right, top to bottom, is peritonitic, like something big and bad has taken over the entire abdominal wall lining. That's a different kind of patient who has just focal peritoneal signs. That's bad enough, frankly. But generalized is potentially really bad. So these patients with the complications that I described usually need admission, if for nothing else, to give IV antibiotics and to get serial abdominal exams. Like, if for nothing else. Surgery, meaning to get involved. If an open surgery is needed, it would be general surgery. Vascular surgery or interventional radiology is often called if there is an abscess that needs to be drained. Sometimes these patients, if they're not looking like super surgical, maybe they'll go to the hospitalist and they'll just get IV antibiotics and kind of serial checks, and like surgery kind of waits in the wings to jump in if needed. These patients are often also on bowel rest in the hospital, because if they got to go to surgery, then we want them ready for that at a moment's notice, right? Our tasks, if we are sitting on the patient because we're boarding, or maybe we're also managing the hospitalist side, watching hemodynamics. We don't want these patients to go into shock, and so we're watching things like heart rate, blood pressure, watching the shock index there. If we have to resus with fluids, resus with pressors, then here we go. We're going to start doing some medicine stuff. Getting surgery or IR on board early. You want to tell them early this patient could go down the toilet, and not like as they are circling the drain. Broad spectrum antibiotics for these patients are helpful. We have some options we'll talk about in a second. Of course, if your patient is immunocompromised, elderly, specifically above 85, because a lot of these studies covering the safety of discharge, they exclude our most elderly patients. So 85 is kind of your cutoff. We're bringing you in, severe peritonitis or not. And patients with pregnancy, those are also at higher risk and can be more complicated than your standard diverticulitis patient.
Or even patients that have had previous diverticulosa that, they know that they have, and you're like, okay, they might tell you they have this severe pain, and all of a sudden, oh, I feel so much better. It's like, because they perfed, and it takes a minute or two, or even 30 minutes to an hour. The literature is really interesting on this, about how patients respond to the pain after a perf. They might feel immediate release, and then they're like, I feel great, send me home. No, 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 no. If you have that kind of severe pain and you perfed, you're going to probably feel a little bit better before you go down the toilet, which is a great phrase that I like to say a lot, and thank you for saying it. Well, technically, I don't like to say it, but I do say it a lot. But I wanted to go back to the disposition and follow-up considerations. So for these uncomplicated discharges, follow-up. Instruct to return if worsening symptoms. That's fever, severe pain, vomiting, inability to tolerate PO. That's the big one. I'm not eating. Come back. After an acute episode, especially a complicated one, a colonoscopy is recommended. Now, this is when you should write this in your discharge paperwork, 6 to 8 weeks, because you also have to think about malignancy, okay? That's something that should also be on your radar. Not necessarily your personal responsibility, but hey, you know what? ER doctors have diagnosed me with lots of issues we've talked about on the show that have literally saved my life. So giving them a time frame is great. For patients with recurrent episodes or complicated disease, elective surgical resection might even be considered. So give them all the options.
That 6 to 8 week time frame is important, because earlier than that, they're at higher risk of perforation, and so it may be kind of a wasted appointment for them to go in like 4 weeks after. GI is going to be like, we're going to do this in a month or so from now, but not right now. So that time frame is so important, and I really do feel like time frames are important in our discharge instructions, right? Someone's got high blood pressure. You're not going to follow up in 2 years. You're going to follow up in 2 weeks to get your blood pressure rechecked.
2 years.
Right? But I mean, that happens sometimes, right? Like they kind of blow it off. So I write in my discharge paperwork, you've got high blood pressure. I'm instructing you to follow up in 2 to 3 weeks.
Sorry, I don't know why that was so funny to me, but it was.
Well, it happens, right? Well, okay, so what does EMRA Antibiotic Guide or other resources say about the treatment in terms of antibiotics for diverticulitis? There's a lot of stuff out there. And this can change as time goes on. And so if you're listening to this in the distant future, then things may have changed. But at the time of this recording, first off, it's important to know what we're killing, because once you know what you're killing, you can kind of know that there are certain bacteria that cover those organisms. Usually it's E. coli, right? Anything abdominal or pelvic, E. coli is towards the top of the list as far as like your usual suspects. Bacteroides, Enterococcus, these are other species that can play a part. If you're going in terms of outpatient therapy, and again, that is for uncomplicated diverticulitis. Outpatient therapy can include 7 to 10 days of amoxicillin clavulanate. Trade name, of course, is Augmentin, but any sort of amoxicillin clavulanate prescription can be good. You could also do combination metronidazole plus a fluoroquinolone, or I'm starting to see cephalexin or another cephalosporin in terms of outpatient, right? This is actually talked about in that JAMA review article, is Keflex plus metronidazole as an outpatient therapy. Why is that? Because of those fluoroquinolone side effects, right? They take your Achilles tendons, they can cause neuropathy, et cetera, et cetera, et cetera. So again, a de-emphasis on fluoroquinolones we're seeing with GI disease. If we're bringing you into the hospital, it's typically metronidazole again, plus a cephalosporin. Ceftriaxone is a fantastic IV cephalosporin. So metronidazole plus ceftriaxone, or if there's a contraindication of ceftriaxone, you could go metronidazole plus a fluoroquinolone, Cipro or Levo. What if somebody is super sick and the diagnosis is to some degree in doubt? You may jump up to something like piperacillin tazobactam, that is considered Zosyn in terms of the trade name. You might throw in a little vancomycin if you're worried about a C. diff or a staph complication. If everything I've talked about is contraindicated or has been failed, we can get into now our carbapenems, right? Imipenem, meropenem. Usually, though, those are kind of under infectious disease lock and key. I've got to ask several people, hey, can I use a carbapenem in this patient? So lots of options here, from the humble outpatient amoxiclav all the way up to the nuclear bomb of carbapenems and everything in between.
You said nuclear bomb. I just want to let you know there's a great Glockenflecken video of him talking about getting approval for imipenem or meropenem. It's hilarious. You just Google him and that, and it's like this doctor walking in and be like, I'd like some meropenem. It's like, what? Like all hell breaks loose. So that's how it is at SFG too. It's like, what the hell do you think you're doing here asking me for this? Like in a really nice way. But like, what is your diagnosis? So really interesting stuff. But here are some key take-home points. If you get a patient with left lower quadrant pain and a fever and elevated inflammatory markers, diverticulitis is your radar. Like that's your thing. It's the radar gun right there for you. CT imaging is pivotal in differentiating uncomplicated versus complicated. So, pull the trigger. Get it. I mean, come on. Not all diverticulitis needs admission or antibiotics. Look at the JAMA article. Read it. Outpatient management can work if criteria are not met, and recent evidence is shifting our practice. So you can send them home. It's okay. Always be vigilant, though, about these bad actors, right? We talked about abscess, perforation, and sepsis, and that can change the game. But discharge planning and patient education are essential to safe outpatient management. And remember, management is evolving, so antibiotics are not an automatic for uncomplicated cases. So keep up with the literature.
If you're sending somebody home, those discharge instructions are really important. What is advised in that JAMA review that we are linking to in the show notes,toview.fireside.fm, is a 3-day follow-up. Send them home if you want to. If they meet the criteria for discharge, fine. Antibiotics, question mark. But tell them you need to come back immediately if you are worse before 3 days. And even if you're not worse, I'd like to re-examine you on day 3. Let's make sure you're not developing peritonitis. Let's not make sure that you're not developing some sort of sneaky stuff here. It might be a nice way to avoid the CT radiation if the patient is amenable to this whole plan of go home and come back if you get worse. So there's that JAMA review. Stat Pearls has a great article out there as well, and that's all going to be in the show notes. As a reminder, reserve your antibiotics for patients with systemic symptoms, fever, chills, nausea, vomiting. Those with leukocytosis, especially if it's trending up over those 3 days, older than 85 or 80, pregnant patients, immunocompromised patients, and just other chronic medical conditions that make you sicker as a whole, right? Like CKD, cirrhosis, heart failure, fragile diabetes. These patients are already kind of like on the tipping point every day. And so you're going to want to be more aggressive with antibiotics in those patients. And we've talked about which ones you would lean towards.
I just thought about a presentation I recently gave to an attending, and my differential included heart failure, renal failure, sepsis, stroke, and generalized unwellness.
That's a broad differential, and I like it.
Dude, this patient was so messed up. I didn't even know where to start, but we did get started. And, it turns out what that patient had was actually an impacted renal stone, which screwed everything up.
Oh.
I mean, this guy had the most severe disease from a renal stone. He had an underlying atrial fibrillation, which has nothing to do with anything we're talking about. But I'm just saying, like, the heart and the kidney were so screwed up that we had failure all over the place. Basically, like the Guns N' Roses song, like, we have failure to communicate here. Nothing was communicating. So in conclusion, Mike, first of all, I love you so much. You did such a great job with being who you are. So congratulations on being a great person. I mean, I don't even know how to sum that up.
Where are you going with this right now?
But I would say that if we want to summarize diverticulitis, it is a severe disease. It affects approximately 180 people out of 100,000 people annually, and it's nothing to sneeze at. So for uncomplicated diverticulitis, the first-line therapy is observation and pain control, and antibiotics should be initiated for patients with persistent problems of the things we talked about and things that you're looking for on your exam. And the treatment of complicated diverticulitis, they can come in. They can get IV antibiotics and potentially, observed and maybe even surgery. But I want you to remember this. Ostomies are sometimes forever, okay? And they ruin people's lives.
Yeah.
And some, yes, ostomies can be reversed. Which brings me to Jim Roberts, who isn't here to HIPAA protect himself, but he was very open about his perforated diverticulitis, where he got an ostomy, and when I was at the age of 14. And that really inspired me to go into the nursing medical field, taking care of him. And it was awful for him to have this ostomy. It was debilitating. I don't know how he did what he did with what he had. And thankfully, he was able to reverse his ostomy. And he lived a much longer, fulfilling life, and we miss him very much. But again, ostomies can be forever. So if you can prevent that, that's great. And if that means deciding doing a CT or talking to a surgeon, freaking do it. Like, what's wrong with you? Just do it. But Mike, I promised our listeners before we get to the trivia question that I would talk just briefly about clinical procedures in emergency medicine. Since we're talking about Jim's health while he's dead, I might as well at least talk about his text.
Yeah.
Jim, again, was very open about his medical problems, and I'm not saying anything that anybody didn't already know. He used to make videos of himself changing his ostomy bag and videos of other patients who were willing to share that. And that's what's highlighted in this text, Clinical Procedures in Emergency Medicine. And Robertson Hedges has been around for a very long time. Jim originally worked on this textbook when he was very young. And the greatest thing
Martha,
about...
I'm so sorry. Can we pause for a second?
Sure.
Let me run to the bathroom real quick, and then we can kind of like restart somewhere else. Or back at the start of this segment. Is that
Sure,
okay?
sure.
Okay, give me a second. Sorry.
Okay. Okay, no problem. We've been going on a long time. Mm-hmm. I know. He's great. Mm-hmm. I know, seriously. I'll pick back up with what did I say? It was a great text. I'll start up with you know what? I gotta pee. I'm gonna go pee. I'm gonna pee. I'll be right back. I've had, okay, hold on. Sorry, Dave.
I'm so sorry. Um, I'm getting to the point. Oh, she's gone now. Oh, that's good. Oh my gosh. I'll tell Martha in a bit, but like, yeah, it's becoming a thing where it's like, you know, I'll tell my kids like, do we have to go to the bathroom before we leave? And part of me is like, I have to ask myself, like, do I have to go to the bathroom before I leave?
I went too. Sorry.
No, I'm glad that my bladder was the impetus for everyone taking a bathroom break. But yeah, Martha, I'm getting to the point seriously, like, where I have to consider like, how much water am I drinking right now? When will I see the next bathroom? Like, I have to be careful about that because it's just like,
I
it
hear
gets
you.
me all of a sudden. I don't know, man. I
I
got
ch-
problems. Oh my gosh, it's it's
Yep.
terrible. Yeah, I have to
Jason's
like stop what
50,
I'm doing.
and we literally had to pull over to the side of the road yesterday. So
Are we just there now? Is that
mm-hmm.
what we're? That's our
Mm-hmm.
life right now.
That's his life, and it will be yours.
It kind of is. Yeah.
All right, I know where I'm going to start up, so we'll
Okay.
round out the stuff. Okay, so
I wanted to make a joke about how like the road to this podcast episode began with Jim's colon. But I don't
go
know where it
ahead.
would fit. I don't know. Because Dave, Dave, you might have to like figure this out in post in terms of like where that line would go.
Well, here, I'll say this thing about how he started writing on his typewriter, and you can then put in that phrase.
Okay, sounds good.
Okay, so take like a good couple second pause here.
Yep.
So the most interesting thing about the text that I just had to put in here is that Jim wrote the original edition #1 on a typewriter. Like literally two fingers, didn't even know how to type well, wrote it with just two little fingers on a typewriter.
Towards the end, he really advanced. I saw him using four fingers typing at the very end. You know, he's really come a long way before. Yeah.
He had.
It's fascinating that the road to this podcast episode began with the colon of Jim Roberts and your whole career as well. So it's pretty wild.
Honest to God, I think he would find that very amusing, and we spoke about that many times.
I'm sure.
Gosh, it's something. But, so's this text. And I really, really, again, I just want to show the book. I really think it's a great book. I know everybody thinks what they do is great. But the cool thing about this book is it's not just what I did. It's what Diane did. It's what all of our authors did. It's what Jim did for 50 years. It is a conglomeration of incredible effort. I mean, the videos are so good. And, Jess and Larry did such a great job. We have tons of doctors on this book and lots of editorial team members. Chenamugan, Chudnovsky, Caldwell, Debleu, Hanley, Hayun, Mayotti, Raven, Sacchetti, Smith, Jeff Tabus, I love you. Also my SFG buddy. And like I said, we have a Farm MD on this too, Korlick. I mean, it is an incredible book. I I could go on,
And
but
it
Mike,
sounds like a real book for 2025 and beyond, right?
yeah.
Like back in the day, it's like, okay, you have texts and you have static pictures. Cool. But it sounds like this text really has embraced the video era,
Well, there's nothing
of
like it. I can tell you
yeah.
that with certainty. There's nothing like it. So if you're interested, go check it out. I mean, you're not really supporting me, you're supporting emergency medicine. You're doing the right thing for your patient. And that's all I care about. I don't give a crap whether or not it came from me or somebody else that helped with this publication. All I care about is that you took care of your patient the evidence based practice way, and we showed you how. So,
I figured it out. It's going to go there. So that's Tintinelli's. This is another emergency medicine book by Matu. Those are the bounce backs book. So this is a primary care procedures book. That's going to go in the trash can because that was my life 15 years ago. It's going to go right there and bump with that primary care procedures book. I've already
you
got
don't need to throw it
space.
in the trash, Mike. What I'm just saying is enlighten yourself to the best, and then maybe you can make a decision. But anyway, I digress. Thank you so much for a wonderful month and a wonderful life in emergency medicine. Let's get to what people really care about, the two of you trivia answer.
Yeah, so our old question first was about good old PJ Gaffney. PJ Gaffney is considered one of the most influential discoverers of the D dimer, that test we love to hate and hate to love. In what year did he first publish his findings about degradation products of cross-linked fibrin? And who was his co-author? The two of you answer is 1973 with co-author Brasher, and the winner is anonymous. This is another time in which the person has chosen not to reveal their identity to the listening audience. Hey, I respect you.
We get that a lot, and it's fine. We're fine
Yeah,
with
it's
it.
totally okay. So
We love you.
congratulations. You know who you are.
Exactly. So our next question for you all to answer, a little twist on what we normally do. Which complication of diverticulitis can present with pneumomaturia and recent UTIs due to an abnormal connection between the bowel and the bladder? The two parts of this question are the bowel and the bladder, but the answer is a two-word answer. So let us know, and you can email us the two-part answer in our email link, which is certainly, hopefully you know, but the 2viewcast@gmail.com. That's the number 2 at, oh gosh, Mike, I really screwed this one up. Can you please read our Gmail address?
I write it phonetically just
What's
for this
wrong with me?
purpose, but that's okay. It's 2view, the number 2viewcast@gmail.com. Gotten some lovely feedback recently. Some people who advised like, hey, I'm coming to the boot camp and like I don't know anybody, but I'm taking a step out in faith, and like it was so great to meet you at the last boot camp. We had a great time and I'm so glad you came. Well, more information on Robertson Hedges. I guess not really. You'd have to go to our website for Robertson Hedges. But the more information on the original and emergency medicine, advanced emergency medicine boot camps, I'm doing it too, the emergency medicine and acute care course, the brain course, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
And as you know, new and upcoming courses, we've got some on the back burner, so be ready. They're going to be announced in 2026. So keep checking back for more on the advanced boot camp and our original boot camps.
Thank you for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcasts, Spotify. Search for Two View Emergency. That's the number 2 View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians get some Two View goodness. If you like YouTube and you want to see Martha's blindingly white blouse, if you want to look at my bookcase, I've got my new awards. They're right over here next to my Mickey statue that Tom gave me. Hello, Tom. Then you can go to the YouTube version, search for Center for Medical Education on YouTube, and you can catch the video version. Don't forget our website where you can go next level on any of our topics we talked about from any of our episodes, including all the papers and sites, including that JAMA diverticulitis review. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett.
Thank you again for tuning in, friends in EM. Share this podcast with a friend and share your thoughts via email. And thanks for sharing your time with us today on the 2View. Have a good day and a great shift.
It's time for a little liquid diet, if you know what I mean.
Oh, I hear you. Jesus.